Hi friends, welcome to World Explorer. Today we are discussing about multiple organ dysfunction syndrome and prevention of multiple organ dysfunction syndrome, and also we will discuss about how to predict mortality of a patient admitted in ICU. How much percentage is the chance of a patient is going to die? That is what we are going to see. By learning this topic, the objective of is you can give counseling to the family members the chance of survival of the patient with confidence. So don't miss any single discussion of this topic. Now, in this topic we are saying about what is multiple organ dysfunction syndrome, what is the SOFA score, what is the Q-SOFA score, and how to predict mortality rates in ICU, and how we can make clinical decisions, and how we can apply in our ICU practice. So what is multiple organ dysfunction syndrome? Multiple organ dysfunction syndrome is a life-threatening illness. This is because of physiological insult occurring to the patient. On ICU admission, we are going to assess the patient, and after admission, we see there is a physiological derangement of 2 or more organ systems of the patient. That means if a patient is admitted and then we are seeing there is a physiological derangement, there is a failure of systems, then it is called as multiple organ dysfunction syndrome. This may be attributed to the uncontrollable infection in the ICU. Next, what is organ failure? If there is an organ failure, for example, if there is a lung failure, the patient is not able to breathe. It will be manifested as decreased SpO2. So what they are doing, we are going for mechanical ventilation. What is mechanical ventilation? We are attaching a mechanical ventilator to the patient, and we are keeping on the mode of controlled mode ventilation or SIMV or CPAP or BiPAP, etc. Whatever it is, we are going to give some support to the lungs of patient so that he can maintain his saturation of oxygen. Next thing is hemodialysis. Once the patient is admitted, he is at risk of going to ARF. ARF is acute renal failure. If patient's intake output, if we are seeing, if there is decreased output, that means patient is going into acute renal failure. Either we have to maintain adequate input and output status, or else if patient is not able to maintain, if there is a kidney failure, if patient may need hemodialysis. Next is using of inotropic or vasopressor agents. If patient is having a low blood pressure, he has to get support of inotropes. And next thing is TPN, total parenteral nutrition. What will happen on the admission? Patient is not going to have any interest to eat. So there is maybe patient is having GI discomfort. So because of this, patient is not taking orally. So in such cases, patient may need TPN if patient is very severely malnutrition. Next thing is respiratory, cardiovascular, renal, hepatic, neurologic, hematology. So these are the 5 systems we are going to concentrate in the organ failure. Respiratory, that is we are seeing for the lung failure. Cardiovascular, that is we are going to see is there any decreased cardiac output, or is there any peripheral vascular neuropathies, or else renal, hepatic, and in the hepatic we are seeing about the liver functions, and we are seeing SGOT, SGPT, bilirubin, etc. And next thing is neurologic monitoring. This is done by the GCS. GCS is Glasgow Coma Scale. And next thing is hematology. In the hematology we are looking for the WBC, because there will be increased WBC in the initial stages of sepsis, or if the sepsis is going to get down, the WBC may be coming to normal. Next thing is, if there is more organ failure, there is a more mortality rate. We also see the edema, inflammation, ischemia, necrosis. These are also maybe the causes of organ failure. Now let's discuss about lung. If there is a normal gas exchange alteration, then the patient is going to have hypoxemia. Hypoxemia means if we can see decreased oxygen in the blood, then it is called as hypoxemia. Now why this is more important for us? Now you see, if there is a decreased oxygen in the blood, there is a decreased oxygen to each and every body part. So automatically what will happen, there is a chance of organ failure. So the causes for this may be lung injury, atelectasis or thrombosis, V by Q mismatch, ventilation to perfusion, and the infection is the common cause. Next thing is barotrauma or volutrauma. What is barotrauma? If a patient is on mechanical ventilation, the patient is getting recovered. After some point of time, once the patient is getting recovered, he may not need the mode of ventilation which we have said. For example, if we have said the CMV, now patient is taking his own respiration, now he is in need of SIMV. So what will happen, there is a mismatch between the respiration effort of the patient and the machine. So what will happen, automatically there is an increase of pressure in the lungs, so because of which there is a trauma to the lung tissues, that is called as barotrauma. Next thing is volutrauma. Volutrauma means if patient is taking his own respiration and machine is giving the more volumes of oxygen to the patient, what will happen, automatically there is an increased volume of air, that is oxygen, in the lungs. So again it may cause the trauma to the patient, that is called as volutrauma. Atelectasis is the collapse of lung tissues. Next thing is, it even progresses to ARDS if not treated. Again it can be manifested as fibrosis, hyaline membrane formation, etc. So this is acute respiratory distress syndrome. So these are all the criteria how we can identify is there a lung dysfunction or not. Next thing, kidney. The main symptom is oliguria. Oliguria is decreased urine output, and second thing is lab value. We are seeing an increase in creatinine level, and we can see fluid electrolyte and acid base balance, and we can see ARF or CRF, and this may be attributed to the nephrotoxic drugs which we are using in ICU. So it is better to stop the nephrotoxic drugs if patient is going into the kidney failure. Next thing is heart. Increased capillary permeability, capillary leak and edema. So this is the cause for patient edema. We see some of the patient is having edema. Next thing is reduced peripheral vascular tone and alteration in the blood flow, microvascular plugging and stasis, arteriovenous stenting, high mixed venous saturation, myocardial depression. So what will happen in the heart? If there is a decreased peripheral vascular tone, we see there is a decreased circulation pattern in the body. So this again may lead to stasis. What is stasis? It is stopping of a flow. Once there is stasis, there is a chance of coagulation. So if there is coagulation, again it may lead to DIC, what we call as disseminated intravascular coagulation. So such type of things again lead to heart failure. Next thing, hypotension. So usually this is manifested as hypotension. Once we see the patient is going into hypotension, again we should be very careful of maintaining the normal blood pressure of a patient with the use of inotropes. Next thing is GI system. In the GI system, once the patient is admitted, they are having the intolerance of enteral feeding. Even they may manifest diarrhea or else abdominal distension like bloating, and there is a hepatic dysfunction, and elevated C-reactive protein and alpha-1 antitrypsin is the lab values we can see, and decreased albumin. Next is neurological symptoms. Glasgow Coma Scale is the assessment tool which we use in ICU. This may be neurological failures is because of iatrogenic, that is after admission because of sedation or analgesics or metabolic alterations, subclinical cerebral edema, reduced cerebral perfusion pressure. So these are the causes because of which patient is going into neurological problems. So peripheral neuropathy is observed in the patients, and polyneuropathy is also seen. Next thing is hematology. In the hematology, we see leukocytosis in the initial stage. Leukocytosis is attributed to the sepsis. Sepsis is nothing but infection. So even we can see mild anemia because of bone marrow suppression. And next thing is thrombocytopenia. We see decreased platelet count in the patients. And next thing is DIC. DIC is disseminated intravascular coagulation. And next thing, this may be attributed to heparin. Once if we are using heparin more and more in the ICU patient, it even lead to thrombocytopenia. So if patient is having thrombocytopenia, it is better to stop heparin. Next thing is immunologic response. In this, it is a delayed hypersensitivity reaction. This is also called as nosocomial or ICU acquired infection. Means patient is not having any infection at the time of admission in the ICU, but he is developed this infection after admitting in the ICU. That is called as nosocomial infection. What are the common microorganisms? Negative staphylococci, enterococci, candida and pseudomonas. Next system we are concentrating is on endocrine. In the endocrine, hyperglycemia and insulin resistance is very common. If patient is having hyperglycemia, that is increased RBS, the patient may need GIK protocol, that is glucose, insulin and potassium. So this type of protocols they are using to correct the hyperglycemia. Next thing is sick euthyroid syndrome and adrenal insufficiency is very common. Now we are going to see what is SOFA score. SOFA score is a tool by which we can assess the or predict the mortality rate of a patient, that is called as SOFA score. So in the SOFA score we are concentrating on the 6 organ systems, that is, and again we are grading from 0 to 4. 0 is the normal and 4 is very severe, and SOFA score greater than 15 is associated with the mortality rate of greater than 80%. If SOFA score is 15, the patient is having 80% chance of going to die. Next thing is SOFA is nothing but sequential organ failure assessment. Calculate SOFA score on the admission and also every day, that is after 24 hours you have to check the SOFA score. Now what is most important here is the criteria which we are considering to include in the SOFA score should be the worst score, that is the maximum score you have given in the last 24 hours you are going to sum up in the next day, that is called as SOFA score. So explain the prognosis to family members. This becomes very easy. If patient is coming, your relatives are coming and asking you, is patient is going to survive or not, you can give the accurate prediction like patient is having a 80% chance of going to death, or if patient is having 80% chance of going to survive. Such type of accuracy and giving health education to the family members becomes easy once we are using SOFA score in the ICU. Next thing is GCS. GCS is Glasgow Coma Scale. Minimum score is 3, maximum score is 15, and the components are eye opening, verbal response and motor response. So total score is 4, 5, 6 is the maximum, minimum is 1, 1, 1, that is 3. So if you need more information about GCS, find the video in my YouTube channel. Next thing is score interpretation of SOFA score. This is I have taken from one website. They are saying that if it is 0 to 6, mortality rate is less than 10%. If it is 7 to 9, 15 to 20%. You can see as the score is increasing, there is an increased chance of mortality. So that is the score interpretation of SOFA. This is the SOFA score table. We can see if there is FiO2 greater than 400, this is normal. Coagulation platelets greater than 1,50,000 normal. Bilirubin less than 1.2 is normal. If there is no hypotension, it is normal. If GCS 15, it is normal. And if urinary creatinine less than 1.2, it is normal. Now we can see as the score is progressing 1, 2, 3, 4. We are seeing FiO2 is going to less than or equal to 100, and they need respiratory support in the score of 3 and 4. And when we are seeing in the coagulation of platelets, we are going to see there is low platelet count, that is even less than 20,000 in 4, and 3 it is less than 50,000. And if it is liver bilirubin, we are going to see greater than 12 mg per dl. In cardiovascular hypotension, the patient's mean arterial pressure is less than 70 mm in score 1. That is, mean arterial pressure is calculated with the formula of systolic blood pressure plus 2 into diastolic blood pressure for whole by 3. So that is how we are going to see the what is mean arterial pressure. And next thing is in the score of 2 and 3 and 4, we are using the inotropes. The patient may be needing the inotropes with the increased dose of dopamine, dobutamine or norepinephrine, whatever it is, we are going to use the inotropes. Next thing is GCS score. We are going to see 15, that is normal in the 0, and once it is less than 6 it is very severe. And we are seeing the urine creatinine, that is if greater than 5 mg per dl the patient is in 4th stage, or if it is 3.5 to 4.9, and SOFA score is we are going to give 2 to 3.4. So if we are able to see all these parameters, and if we are able to add the worst parameter in the last 24 hours, we are going to get the SOFA score, and based on this we are going to predict the mortality of the patient. Next is Q-SOFA score. This is a modified version of SOFA score. So this is quick sequential organ failure assessment. They are using only 3 parameters here. Respiratory rate, if greater than 22 they are giving 1 point. If change in mental status they are giving 1 point. And if it is systolic blood pressure less than 100 mmHg it is 1 point. So they are using these 3 parameters, and if the score is 2 points or more, then they are going to say this is an organic dysfunction. Now sepsis 3.0, they are using the Q-SOFA score. In this GCS, if less than 15, respiratory rate greater than 22, heart rate less than 100 mmHg. So that is the Q-SOFA score. Next thing is prevention of multiple organ dysfunction syndrome. First thing is strict infection control policies of the ICU. Next thing is prevention of respiratory infections such as ventilatory associated pneumonia. Next is minimize the barotrauma and have weaning policies in the ICU. Next thing is avoidance of nephrotoxic drugs, stress ulcer prophylaxis with H2 blockers, and enteral nutrition, DVT prophylaxis with SCD, that is sequential compressive devices, and the next is SDD, that is selective decontamination of digestive tract. This is the reference from which I have taken the information, and if you like this video, subscribe, comment and share to your friends and family members. Thank you.